चेतन जी, ये राहुल बेंद्रे सर आए हैं, इनको आप पैनलिस्ट बना दो। राहुल बेंद्रे सर, यस।
ओके सर।
Chetan ji, are we live on YouTube?
Yes, sir. We just live on YouTube. We are not live on attendee link still.
Okay. So
Yeah.
the Mankind Curis link, we can see this. I'll just check. Yes.
Yeah. We actually we are not live on this link because I'm just putting live on YouTube. Then this YouTube link we will copy on your attendee link. Then that time
Okay.
we will, can see. Yeah.
Okay. Very good evening, sir.
Good evening.
Yes.
Let us just do a share screen and test.
Yes. Yes.
Are the slides moving?
Yes, sir.
You are
Yes.
able to see? Good.
We are able to see also, and animations are also visible.
Very good. Excellent. That is good. Let us stop sharing. We have about 10 minutes.
Yes, sir.
All right. Anything you want to say?
Yes, sir. I'll be introducing you. So, sir, we'll start off the session, and then I'll hand over the session to you. And
All right.
we'll go live at 5:55, 5 minutes before. Yeah.
Okay.
We'll go.
Okay. Right. Yeah.
Chetanji, can you please let Praveen sir in? Can you please call Praveen sir in? Yes.
Yes, sir.
Chetanji, we can go live.
Okay,
I
sir.
think we can start going live right now. It will take a couple of minutes, so I think we can.
Ritesh, sir, we are live now. Ritesh, sir, can you hear me? Hello. Hello, Ritesh sir.
Yes.
Yes, we are live now.
Okay. Okay. So, sir, we'll start at 6 o'clock. We'll start at sharp 6 o'clock. Sir, I think 5:59 is there. Chetanji, are we good to go?
Okay, sir.
Okay. So we are visible on YouTube, right?
Yes, yes, we are visible on this attendee link. So now.
Okay. Okay. Sir, should I start?
Yes.
Okay. Okay. So we are starting, right? Okay, Chetanji, should I start now?
Yes, sir. Yes.
Okay. So, a very good evening to all of you. I welcome all the esteemed participants, all the doctors, everybody that is listening to us. I welcome our esteemed faculty, Dr. J.C. Mohan, sir. Sir, welcome you. Sir, as you are, I think everybody is aware that right now in the country, we are facing a second wave of COVID-19. And Mankind and Curis Mankind Specialities stands with doctors, and as a partner we are really looking forward to help everyone that we can, as these are very difficult times. So based on what we have seen all across the country, we have organized this small seminar. As sir, you are a pioneer in the field of cardiology, so I think we are really looking forward for you to deliver a very important lecture on anticoagulants and COVID-19. Before we hand over the session to sir, I would just like to introduce sir, Dr. J.C. Mohan, sir, an MD DM in cardiology. He is currently the chairman of Institute of Heart and Vascular Diseases, Jaipur Golden Hospital, New Delhi. Sir was the consultant emeritus at Fortis Hospital, Shalimar Bagh. Dr. J.C. Mohan, sir, has over 300 index publications, 2 books, and 76 book chapters to his credit. As a professor of cardiology at GB Pant Postgraduate Institute of Medical Education, he spent around 19 years. Dr. J.C. Mohan, sir, has been the past president of the Indian Academy of Echocardiography and CSI. Sir is currently the president of Apex Society for CME in Cardiology. Sir, I welcome you on behalf of Curis Mankind Specialities and thank you for giving us your time. Over to you, sir, and so we can start the session now.
Thank you, Ritesh. And thank you, Curis Mankind Specialities, for inviting me for this important webinar, wherein we would be discussing the role of anticoagulation therapy for preventing arteriovenous thromboembolism in COVID infections, and we would be focusing on rivaroxaban. As Ritesh rightly said, we are passing through the pandemic of COVID infections, and it is a deadly disease. We also have realized that whatever evidence we have got for saving lives lies either in steroids or in anticoagulants. So we today would see where do we stand with regard to anticoagulant therapy in patients who are suffering from COVID infection. Thrombosis kills 50% of mankind, direct or indirect. The direct is because of myocardial infarction, pulmonary embolism, stroke, acute limb ischemia, and indirect as you are nowadays seeing in COVID infection because of pulmonary intravascular, disseminated intravascular coagulation. And there are 3 distinct pathways which are involved in thrombosis: platelet pathway, inflammation pathway, and thrombin pathway. In COVID infection, inflammation pathway and thrombin pathways play a major role, and we have to deal with these two pathways separately. Acute vascular events, which are occurring so commonly, are occurring in 1/3 of all hospitalized patients with COVID infection, essentially start as a mural platelet thrombus, either in arteries or veins, and then it is followed by luminal fibrin-rich thrombus. That phase of platelet thrombus is actually very quickly replaced by large occlusive fibrin-rich thrombus, and because of that, there is a much, much bigger role of antithrombin therapy than antiplatelet therapy in COVID infection. We know that there are two distinct pathways of coagulation. Both pathways are activated in patients with COVID infection. Because of injury to endothelium, there is a tissue factor which is released, which activates the extrinsic factor. And because of inflammation, the platelets get activated on platelet surface, intrinsic coagulation pathway gets activated. The end result is production of large amount of thrombin, which converts fibrinogen into fibrin. And finally, fibrin is degraded, and we see a lot of fibrin degradation products as D-dimer. So D-dimer are the way we find out that coagulopathy is occurring in COVID infections. We have drugs which work either on one of the pathways, one of the specific factors. For example, we have anti-10A agents like apixaban, rivaroxaban, adoxaban, betirabex. And we have, of course, direct thrombin inhibitors like dabigatran. The indirect thrombin inhibitors like low molecular weight heparin, fondaparinux, and unfractionated heparin are also playing a big role in management of critically ill COVID patients, and we would not ignore mentioning these. But in general, whichever way thrombin is generated and whichever way it is inhibited, we need to remember that thrombin is at the core of the problem. Thrombin generation defines STEMI, ischemic stroke, DVT, and pulmonary embolism, which are common, and other types of vascular thrombosis and predict the outcome. Typically, normal prothrombin levels are 100 microgram per ml and normal thrombin activity less than 5 milli international units. And there are natural antithrombin 3 levels, which are about 17 to 30 milligram per deciliter. It so happens that in COVID infection, especially symptomatic COVID infections, the prothrombin levels go up, the thrombin activity actually goes up, and the natural antithrombin 3 activity markedly goes down, resulting in disseminated coagulopathy. So once having talked about coagulation and thrombin, naturally we need to find out, we need to understand what is an anticoagulant. Obviously, any agent which will inhibit the thrombin generation or its action would be called an antithrombin agent or an anticoagulant. And we have three distinct classes. We have heparin and heparinoids, we have vitamin K antagonists, and we have direct acting oral anticoagulants like rivaroxaban, apixaban, and of course dabigatran available. Coming back to the issue of coagulation and SARS-CoV-2 infection, SARS-CoV-2 infection is characterized by hyperinflammatory state and hypercoagulopathy. The hyperinflammatory state is also called cytokine storm, which typically occurs on 5th day, 4th day, 6th day of infection, and hypercoagulability just follows that cytokine storm. And we, of course, are able to detect cytokine storm either because of high-grade fever or rise in inflammatory markers like CRP, ferritin, LDH, and IL-6, to name a few. So coagulopathy in COVID-19 infection is a burning issue because it is so frequent, and it is one of the ways prognosis becomes poor and people die. Strategies to prevent thromboembolic events are debatable, and these will remain debatable till data from randomized trials becomes available, and these are highly heterogeneous. So it is possible that you might see in the city 10 people practicing different ways of anticoagulation, and they all may be right and they all may be wrong. At this moment, we have no idea. Nevertheless, anticoagulation do help many people. These don't help everybody. The issue is what should be the intensity of anticoagulation, when to initiate anticoagulation, and who would benefit and who would not benefit. But again, coming back to the fact that the players which have franchisee in thrombosis are coagulation controlling proteins, endothelial cells, thrombin, and platelets. Remember, all these four players are altered in COVID infection. So typically what happens is that a large amount of thrombin is generated in COVID infection, especially after the cytokine storm. And when thrombin is generated, this leads to activated monocytes, activated endothelial cells, activated platelets, and the end result is an endless loop where these cells not only contribute to inflammation, but these also contribute to large amount of thrombin generation. So thrombin generation begets thrombin generation, and inflammation begets inflammation, and also vice versa. We are also aware of the fact that thrombus is of two types, fibrin rich and fibrin poor. Fibrin poor is largely platelet rich thrombus where antiplatelets are important, but in COVID infection, largely it is fibrin-rich thrombus which plays a big role, and hence there is need more of antithrombin therapy than antiplatelet therapy. And hence we have very little data with regard to use of antiplatelet drugs in COVID infection. Coming back to the SARS-CoV-2 infection again, since it essentially starts as a pulmonary infection, there is alveolar damage, there is inflammation, there is coagulopathy because proteins are increased, and there is endothelial dysfunction because of the cytokine storm. So coagulopathy and endothelial dysfunction lead to thrombosis. How do we know thrombosis occurs in COVID infection? Well, in general, half of the patients have elevated D dimers, and unselected, 2/3 of the patients have increased fibrinogen, indicating increase in the coagulation protein. How does thrombosis manifest in SARS-CoV-2 infection? Usually there is a diffuse pulmonary arterial microthrombi, which have been seen on autopsies. And of course, we regularly see more patients with STEMI, pulmonary embolism, stroke, and of course, acute limb ischemia, which are macrothrombotic events. Also, DVT occurs quite frequently. So we are seeing both of these conditions, and those are as a result of thrombosis. So eventually, the virus enters the alveoli, damages the pneumocyte 1 and pneumocyte 2, and since the capillaries are present adjacently, these capillaries, because of these inflammatory substances and also because of antigen-antibody complex which is formed, will damage the endothelium, also release the tissue factor, finally result in disseminated intravascular coagulation in lungs, and that is how the COVID pneumonia essentially presents and progresses. But we can have thrombi in arteries per se, which of course can lead to stroke and acute coronary syndrome. We can have intracapillary or microvascular thrombosis, which results in the so-called DIC. And then we have venous thromboembolism, where you have venous thrombosis, superficial or deep, and then may result in pulmonary embolism. Data actually from, this is data from Mass General Hospital. They have several hospitals in their network. And this data, which they published about 6 months back, shows that about 38% of all hospitalized patients have evidence of arterial or venous thromboembolism. Those who are in ICU develop far more than those who are in ward, non-ICU. Obviously, those who are in ICU are hypoxic, they are critically ill, and they need some kind of support. So people who are on support have much more arteriovenous thromboembolism than those who are in hospital. But this data is despite anticoagulation, despite anticoagulation. So one can imagine that if anticoagulation prevents thromboembolism to 70-80%, then probably everybody in ICU would get thromboembolism in case they're not on anticoagulants. And in non-ICU setting also, maybe 10-15% patients will develop arteriovenous thromboembolism. So the coronavirus coagulopathy is as a result of septic inflammation and presents like DIC. And acute phase reactants are increased, fibrinogen factor 8, there is thrombocytosis, platelets are increased. There is DIC, and DIC can be followed by low fibrinogen levels, low platelets, elevated PT, PGT, and D-dimer. And remember, coagulopathy is common in sick COVID-19 patients. It's far more common in non-survivors than in survivors. And similarly, DIC is far more common in non-survivors than survivors. But we need to keep in mind one thing, that anticoagulants in COVID infection could be double-edged sword. Why? Because COVID pneumonia has two phenotypes. It could be thrombophilic type, where anticoagulants will work and prevent damage. It could be hemorrhagic type, which is in which, of course, anticoagulants could be harmful. Nevertheless, the thrombophilic type COVID pneumonia is far more common, and hence we believe that by and large anticoagulants will help sicker patients with COVID pneumonia. But we also have to keep in mind one thing, and that is when you use anticoagulants like rivaroxaban or heparins, the thrombotic risk and bleeding risk both are coupled. And the thrombotic risk and bleeding risk both increase based on quantitative scores. We certainly would like to give anticoagulants in case the thrombotic score of thrombotic risk is high. And I'll show you one of the ways score system, but you can use your common sense. Elderly people, people with prior cancer, people with prior thromboembolism, people with paralysis, people who are hospitalized are likely to have more thrombosis. And people who have hepatic or renal dysfunction, thrombocytopenia, prior bleeding on non-steroidal anti-inflammatory drugs, use of alcohol, age, of course, these people will have higher bleeding risk. The two risks are coupled, and fortunately, we also have realized that NOACs or DOACs actually produce uncoupling of these risk factors, although these have not been specifically tested in COVID infection, but one can use common sense and say these would be better actually in COVID infections, especially those who have come out of the hospital and those who have not been able to get bed, or those who are being treated at home, although being moderately sick. So far, the data suggests all over the world that thromboembolism occurs in 20 to 69% of critically ill patients. That is a large number. But the word is critically ill. So obviously, moderately ill patient will have much less thromboembolism. The number, it is difficult to judge. But in case you believe in D-dimer being a marker of thromboembolism, then probably 40% of all COVID infections who need hospitalization would have actually evidence of thromboembolism. What is disturbing is that the breakthrough thromboembolism are common in COVID. That means arterial and venous thromboembolism occur despite anticoagulation. This is because the forces of coagulopathy overcome the anticoagulation forces more often than not. The other important thing which we need to keep in mind is that thrombus formation does contribute to mortality. So coagulopathy is a poor prognostic factor, and we need to develop optimal strategies for early diagnosis, prevention, and prompt treatment of thromboembolism in COVID-19 patients. Again, this data from China, Wuhan, actually one of the original data, looked at the fact that those patients who developed deep vein thrombosis had poor survival compared to those who did not develop DVT. DVT can be easily checked clinically and also by Doppler ultrasound, which is so easily available in ICUs, and those who develop DVT are at a high risk. There is also a 13 times higher risk of developing DVT in those who have D-dimer more than 1000 nanogram per ml. So one of the ways one could say is that people who have D-dimer level more than 1 microgram per liter or more than 1000 nanogram per ml are the ones who are likely to have DVT because the odd ratio has been shown between 13 and 18 times. And one need not do venous-graphy. D-dimer alone can be used as a predictor, and hence one could decide on using anticoagulant. Higher is the D-dimer, greater are the chances of DVT, and greater would be need for anticoagulation, and probably that you could justify. One thing which we need to remember is that the D-dimer levels slowly rise over a period of time. So one reading may not be sufficient, and one reading may not be able to tell what is the risk of the individual with regard to arteriovenous thromboembolism. Again, this data from China, published in Circulation from Wuhan, shows you the natural history of D-dimer levels, platelets, prothrombin time, and APT time. Let us concentrate for the moment on upper left corner. Those who survive, those who have DVT. Let us talk about those. Those who have DVT, their D-dimer levels right from the beginning, fourth day, that means fourth day infection is already around 1500 nanogram per ml, and it starts rising slowly and peaks around 20 days. Peaks around 20 days and then starts falling and tends to become around 2000 nanogram at 34 days. Now, because of this kind of behavior of the D-dimer, it has been suggested that in case you find, and these are individuals who have developed DVT, and when you see the blue bars, it shows that people who do not develop DVT, they also could start with the same D-dimer level of 1500 nanogram, but in them the D-dimer level actually remains stable or rather falls over a period of time. And hence, progressive rise in D-dimer probably would be the strongest indication for initiating anticoagulation. And how long you should continue, the data of course suggests that at least for 35 days and maybe 2 weeks more, and hence currently most people believe that 6 weeks of therapy or 45 days of anticoagulation therapy would be a good way of taking care of post-hospitalized patients. Platelet levels do not decide prognosis or chance of developing DVT, as you can see in the right upper column. So is the prothrombin time and so is the APT time. So of all, if we have to actually rely on one single parameter to decide whether patient is at a risk of developing venous and or arterial thrombosis, it is D-dimer level, and one D-dimer level is not sufficient. You probably have to do serial studies to find out what is the risk of the individual. The good thing actually, beyond the China, also D-dimer level have been shown to be predictive. The French study of non-ICU hospitalized COVID patients suggests that in case the D-dimer level is less than 1000 nanogram per ml, it has a negative predictive value of close to 90%, and for negative predictive value for pulmonary embolism, 98%. What does it mean is that in case the D-dimer levels maybe on at the beginning and maybe a week down the line is less than 1000 nanogram, chances of thromboembolism are very, very low. So routine, and this has been correlated with routine venous Doppler and chest CT angio in all patients. So the strength of the study lies that every person underwent CT pulmonary angiography and routine venous Doppler study. It clearly indicates that 1000 nanogram per ml or 1 microgram per liter of D-dimer is the threshold we should be looking for in deciding whom we need actually to treat, provided the other risk factors also suggest need for anticoagulation. So here is again another Chinese study, actually the initial Chinese study actually which came out of Wuhan, showing that D-dimer levels in hospitalized COVID patients in survivors, again look at the left upper corner, please concentrate only of the left upper corner at the moment, and you would see that in survivors, actually the levels are closer to 500 nanogram per ml, and they stay so throughout the 3 weeks patient in the hospital, as shown in blue bars. The non-survivors show a progressive rise in D-dimer, and the D-dimer keeps rising, and it has been shown to be rising till the time of death. 42, it is 42 microgram per liter actually. It goes on. This is what happens. So progressive rise in D-dimer certainly is a bad prognostic factor and also tells you need for anticoagulation, maybe even therapeutic anticoagulation. We'll come to that, which is again a controversial issue. The other factors which decide prognosis are lymphopenia on right upper part, but it's not a very strong predictor. On the other hand, IL-6 and serum ferritin are strong predictors of mortality. Progressive rise of IL-6 and progressive rise of serum ferritin suggest increased chances of patient not surviving the hospital admission. So it has been suggested actually by the International Society of Thrombosis and Hemostasis in its interim guidelines actually published sometime in the end of last year that those who have D-dimer level more than 4 times or whose fibrinogen level is less than 2 gram per liter or who have thrombocytopenia or whose platelet thrombin time, the prothrombin time is increased, they should, any of them when it is there, patient should ideally be admitted, monitored, and low molecular weight heparin should be started. Now, this is one of the algorithms which has been suggested based on simple laboratory markers, clearly indicating that these are the individuals who are likely to having both hyperinflammation and hypercoagulation. However, there is again this controversy of whether there should be prophylactic anticoagulation or therapeutic anticoagulation. And we have no single data to suggest that therapeutic anticoagulation is better than prophylactic anticoagulation. And this is being hypothesized that therapeutic anticoagulation may be beneficial for critically ill patients and is a focus of 39 ongoing randomized trials in COVID infection. You can see how much is the interest as far as anticoagulation and COVID infection is concerned. That is the largest number of randomized trials started in a short period for any condition. This issue of anticoagulation came out when last April actually, and last May to be precise, the Mount Sinai Hospital, New York guys actually produced their observational data of nearly 4,400 patients. All these were hospitalized patients, and these people actually were given either anticoagulation prophylactic dose, which of course is 40 units of subcutaneous low molecular weight heparin, or therapeutic anticoagulation, which is 1 milligram per kg of body weight given twice a day, or none. And also they did use apixaban also, and they did not use rivaroxaban, but they also use unfractionated heparin, wherefore also the prophylactic dose is 2,500 to 5,000 units subcutaneous every day, and the therapeutic dose actually is 5,000 units 3 times or 4 times a day. Nevertheless, this data from the Mount Sinai Hospital, spearheaded by Valentine Fuster and the first author being Girish Nadkarni, showed that there is 50% lower mortality in those who have been given anticoagulation during hospital stay and later on. And whether you gave therapeutic anticoagulation or prophylactic anticoagulation, the benefit was similar. Now, this is all the data we have got as far as anticoagulation is concerned. This is the large data, observational data. Obviously, it will not make it a class 1 recommendation, but observational data makes you have class 2 recommendation that you can use either prophylactic anticoagulation or therapeutic anticoagulation, depending upon your clinical judgment. Anticoagulation also prevented intubation by 31%, and major bleeds were there. In prophylactic anticoagulation were 2%. In therapeutic anticoagulation, it was 3%, which of course are probably acceptable to us. However, the interesting part is the European data is at variance with Mount Sinai data, and this is data from the Europe. 28 ICU centers of Europe of non-mechanically ventilated patients, and their data clearly says that better survival is there with enhanced prophylaxis. So these people are saying that standard prophylaxis and no prophylaxis, right at the bottom, have similar survival. It is when you give enhanced prophylaxis and largely with the low molecular weight heparin that you see better survival benefit. But it also actually has used enhanced prophylaxis with DOACs, and here all kinds of DOACs have been used, including rivaroxaban, and the uppermost column, uppermost part of this graph shows that the survival is best in case enhanced prophylaxis with non-low molecular weight heparins has been used. Now that is an interesting thing. But remember, again, this is data of 852 patients, and it is observational data. It only says anticoagulation does help patients for better survival. But what should be the intensity is controversial, because the Mount Sinai data says the intensity doesn't make a difference, while the European data says intensity of anticoagulation does make a difference. Having said that, let us come to the role of rivaroxaban in patients with COVID infection. At the moment, we are seeing rivaroxaban being used in nearly 50% of all COVID patients who actually have moderate or severe infection. At least in the city of Delhi, this is what the practice is, and elsewhere also. Rivaroxaban, the advantage is it is once a day dose, and there is a large amount of prophylaxis data already available in other conditions with rivaroxaban. It is a competitive and dose-dependent direct inhibitor of factor 10A, and it is rapidly absorbs, reaches peak plasma concentration within 2 to 4 hours after oral administration, and it can be given once a day, and its renal clearance is 35%, so largely even up to 30 ml EGFR, it can safely be given without changing the dose of prophylaxis. That is interesting. You can give 10 milligram a day dose for adult patients without changing up to an EGFR of 30, and below 30 is not approved, and there probably, if you want to use DOAC, you would have to use apixaban or unfractionated heparin, because even low molecular weight heparin and fondaparinux are not to be used with EGFR less than 30. Site of action rivaroxaban, we already know it is factor 10A. The factor 10A actually works on factor 2 or prothrombin to convert into thrombin, which is an enzyme which converts fibrinogen into fibrin. So factor 10A is actually not allowed to work and this is a competitive inhibitor of factor 10A, rivaroxaban, and that is how there is less thrombin generation when you use rivaroxaban. Data from rivaroxaban has been shown that it reduces chances of venous thromboembolism, which occurs in 1/3 of COVID infections by 90%. And hence you would get almost similar kind of benefit or protection when you use in COVID patients. Cardiac thromboembolism reduced by 80%, and this is also an important issue. Atherothrombosis is reduced by 40% when you use rivaroxaban on top of aspirin. But the prevention therapy, the randomized trial, the Prevent HD study is still going on with rivaroxaban in patients who are outpatient with COVID infection. So we don't have data at this moment, strong data that COVID-19 outpatients, those who are being treated at home, should they be given definitely rivaroxaban as prophylaxis therapy? Everybody. So to find out whether they should be given or who should be given, Prevent HD study is going on. And this month only, the rationale or design of this study has been published in American Heart Journal, May. But I did tell you that if I have to use anticoagulation, I'll use NOACs rather than the conventional drugs, VKA or heparin. And the reason is uncoupling between thrombotic risk and major bleeding is far better with NOACs like rivaroxaban than with vitamin K antagonists and heparin. However, where should we be using this prophylactic dose of anticoagulation? Data from Mariner study, which had some positive things and some negative things with regard to venous thromboembolism prophylaxis with rivaroxaban, showed that in case you use this improved risk score of 4 or more, or if the score is 2 and D-dimer levels are twice or more, the patients would be benefited. So here is the actual risk factor. Obviously, we all know it: previous venous thromboembolism, known thrombophilia, low limb paralysis, and history of cancer get high points. And probably if associated with age above 60 years, all of them are candidates for prophylaxis with rivaroxaban. Mariner study, which actually was a medically ill hospitalized patient for 3 to 10 days, and after discharge, they were given rivaroxaban 10 milligram a day largely, and some were given, of course, 7.5 milligram based on creatinine, compared to placebo to see whether the patients are benefited for next 45 days or not. There was a definite trend in favor of rivaroxaban prophylaxis in these acute medically ill patients, 24% risk reduction, not reaching statistical significance because here the primary endpoints were death because of thromboembolism plus DVT, symptomatic DVT. And symptomatic DVT was markedly reduced by 56%, but death wasn't changed by rivaroxaban. And hence, because of this reason, the study actually was largely negative. But one thing is clear, that if you look at only symptomatic venous thromboembolism, these were reduced by almost 50%. Secondary, there were many secondary endpoints, and all secondary endpoints were in favor of rivaroxaban in medically ill patients who were discharged after hospital stay. The Mariner study, 10 milligram rivaroxaban, also told us that there is a chance of bleeding, which is 1 in 400, 0.28%, which is nearly twice more than placebo. Non-major clinically relevant bleeding occurs in about 1.4%. So out of every 100 patients, you can expect 1% to have non-major clinically relevant bleeding, which could be epistaxis, which could be a spontaneous hematoma, which could be there in the leg or muscle, and so on and so forth. That we need to keep in mind when we are using rivaroxaban. Obviously, the bleeding risk score, blood score has to be used. Higher is the risk score and higher are the chances of bleeding. The other prophylaxis study, which is not in COVID, but otherwise has been done in medically ill patient called Magellan. Magellan again is a large study of 8,000 patients, and this showed that primary prophylaxis in medically ill patients actually comparing actually subcutaneous enoxaparin and rivaroxaban were similar. It clearly indicates one thing, that within the hospital, now this is in hospital, unlike Mariner study, which was out of the hospital, this is an in-hospital study. And in-hospital study clearly says that the two drugs are equal. Low molecular weight heparin is equal to 10 milligram rivaroxaban for preventing venous thromboembolism. In both the conditions, it occurs in 2%. Bleeding is slightly more with rivaroxaban compared to enoxaparin. The reason is the enoxaparin has been given only for 10 days and rivaroxaban for 35 days. Clearly, the duration will make a difference with regard to bleeding. But more important is that it is as effective as low molecular weight heparin, but there is a large convenience in giving an oral drug rather than giving a subcutaneous enoxaparin. Cost advantage also is certainly there when you use rivaroxaban. But rivaroxaban is not effective in all patients with venous thromboembolism or reducing mortality. The commander HF data is in patients with heart failure, and rivaroxaban in heart failure patient here did not show any great benefit. And we need to keep in mind that you can't be using rivaroxaban in each and every patient. However, very interesting data actually came out of the Magellan study when you looked at thromboprophylaxis with rivaroxaban among patients recently hospitalized with acute infection, especially lung infection. So let us only concentrate on lung infection that is shown in red bars. And here the comparison between enoxaparin 40 milligram versus rivaroxaban 10 milligram. You can clearly see that if patients have lung infection, then rivaroxaban scores over enoxaparin by a large extent. There is a greater 50% reduction in symptomatic DVT with 10 milligram rivaroxaban compared to enoxaparin. And not only at 10 days it is 50%, it is 46% at 35 days. Clearly telling that if you have to use in patients who have suffered from a lung infection, rivaroxaban is superior to enoxaparin for thromboprophylaxis. So let us come back now to the recommendations. How are the anticoagulation recommendations in patients with COVID infection? And these are last month's recommendations by the American Society of Hematology. And it says that prophylactic intensity over intermediate intensity anticoagulation should be used in patients with coronavirus disease who have critical illness and who don't have suspected or confirmed venous thromboembolism. So essentially for prophylaxis, the data suggests you should use prophylactic intensity therapy and not intermediate intensity therapy. That has a class 1 recommendation. Clearly, it means that if the patient has critical illness, that means hypoxia, dyspnea, hospitalization, you should be using prophylactic intensity, 10 milligram rivaroxaban or 40 milligram enoxaparin compared to the therapeutic doses. These guidelines also suggest that an individualized assessment of patient risk for thrombosis and bleeding is important when deciding on anticoagulation intensity. So everybody, you can't be using high intensity anticoagulation everybody, but some patients may be candidates for this. Risk assessment models to estimate thrombotic and bleeding risk in hospital patients haven't been validated in COVID. That is clear. We don't know who should be getting anticoagulation, who shouldn't be getting, and in what dose they should be getting. Again, we need to get this answer from randomized studies. However, the ASH panel last month acknowledged that high intensity anticoagulation may be preferred for patients just to be at high thrombotic risk and low bleeding risk, but we don't have data as of now. So at present, there is no direct high certainty evidence comparing different types of anticoagulant. That is another point which has brought our ASH. It doesn't say one over the other. It only says we don't have high certainty data that one anticoagulation like LMWH or heparin needs to be preferred over rivaroxaban or apixaban. The selection of a specific agent may be based on availability, resource required, familiarity, and aim to minimize personal protective equipment. And patient-specific factors like renal function, history of heparin-induced thrombocytopenia, and concerns about GI bleed, GI absorption need to be kept in mind. Obviously, we know that many of these people would be much better off with oral 10 milligram rivaroxaban than enoxaparin from multiple viewpoints, because this reduces the exposure to the healthcare personnel. Giving an oral tablet is different than giving a subcutaneous enoxaparin. The recommendations of the ASH of February 2021 suggest that prophylactic intensity over intermediate intensity or therapeutic anticoagulation in patients with COVID-19 related acute illness is to be preferred. And who are these people? People who have dyspnea or mild to moderate hypoxia. And these are people who don't have a confirmed venous thromboembolism. So clearly, the data at this time suggests to use prophylactic dose of anticoagulation, largely rivaroxaban 10 milligram or enoxaparin 40 milligram or unfractionated heparin 5,000 units or apixaban 2.5 milligram twice a day, rather than therapeutic dose, because again, as it said, the Mount Sinai data does not show any difference between the two intensity, and randomized trials are missing. So based upon very low certainty evidence, WHO recommends use of low dose anticoagulation. Now WHO also suggests that you should use low dose anticoagulation because there is a chance of hemorrhage in the lungs with high intensity statin therapy. On the other hand, the NIH in United States have taken a little more pro full dose anticoagulation approach, and it says maybe the vital organ support can be provided more. It reduces the need for vital organ support if you use full dose anticoagulation, but this is their viewpoint, and it needs to be confirmed by randomized trials. High dose of blood thinners to patients who are not already critical ill should become standard of care, is what the NIH is thinking, but we of course need data. Remember, these are all opinion of experts. So, ladies and gentlemen, to summarize, the field of anticoagulant therapy in high-risk COVID patients is evolving rapidly, but it does appear that prophylactic anticoagulation therapy is required in a large majority of patients who are symptomatic because of dyspnea, hypoxia, or hospitalized, who are in ICU or who need mechanical support of any kind. Thank you very much.
Thank you so much, sir, for such a wonderful talk. I think for the last 1 hour or so, we were very patiently listening to everything that you were telling us. Sir, will we be taking some questions?
Yes, yes, please.
Okay. Sir, I would like to just inform you that we have got more than 50 questions, in today's CME. So I'm going to summarize some of the questions for you. Sir, my first question, I think a lot of questions were coming in. A lot of questions were coming in for aspirin, usage of aspirin, post-COVID. After discharge, like how should you use aspirin? Is aspirin enough? And somebody even asked that, how do you compare it with Novax?
So so far the data suggests people who are already on aspirin because of previous vascular event should continue aspirin. And in case they need prophylactic dose of anticoagulation, it can be added on it. However, you should avoid adding a prophylactic dose of anticoagulation on DAPT, and if possible, you should continue one of the antiplatelet drugs. But initiating aspirin in COVID infection is not recommended. Here, the issue is to give an antithrombin therapy rather than an antiplatelet therapy. And we have no data.
Right. Right. So, answer one question has just related with it. Can we start a prophylactic anticoagulation therapy irrespective of D-dimer level or with normal D-dimer?
This is what is being practiced in this city. Large number of people are giving. If you don't want to do D-dimer, you can clinically decide the severity of infection of the patient. If the patient has high-grade fever on 4th, 5th, 6th day, chances that this is cytokine storm, it will be followed by hypercoagulability, you can start. If the patient has hypoxia, if you have certainly saturation low, these are people who definitely are significantly ill, because hypoxia itself leads to disseminated coagulation, and you could start with prophylactic therapy.
We can start.
But certainly not in everybody. Probably a good number, might be about 40% are candidates for prophylactic anticoagulation.
Right. Sir, there were 3 to 4 questions regarding the dose of anticoagulants. Like you referred to low dose and intermediate intensity of anticoagulants. So what is the right dose? Like for an example, if you're using rivaroxaban, what is the right dose to give?
So the prophylactic dose of rivaroxaban is 10 milligram a day, or apixaban 2.5 milligram a day. The guidelines are silent as far as dabigatran is concerned.
Okay.
But as far as low molecular heparin is concerned, it is 40 milligram subcutaneous once a day. For unfractured heparin is 5,000 units once a day. For fondaparinux is 2.5 milligram subcutaneous once a day. These are what is called low intensity or thromboprophylaxis dose of anticoagulation.
So basically all these drugs we can use in COVID-19.
Yeah, we can use any of these drugs depending upon your choice. Some people actually initially came up with the idea last year that maybe heparins have pleiotropic benefit with regard to suppressing inflammation and maybe better.
Okay.
And this view was taken by some of the recommending bodies, but the American Society of Hematology clearly suggests that at this moment there is not enough data to prefer one anticoagulant over other.
Okay. So we should have access to all the anticoagulants.
Yes.
in this time. Right, sir. Sir, I would just take one more question. Somebody has asked, only fever is there, no dyspnea, no hypoxia. Should anticoagulation be preferred here? I think a lot of people are asking regarding that phase where still D-dimer is not positive. I think that is a question a lot of people are still asking.
But here I think you should use that impact score. You can use many scores. Padua score is available, impact score is available. If the score is more than 4, the impact score is more than 4, there is no harm in starting. For example, if somebody is above 60 years of age and have a cancer, had a previous cancer treated, would definitely be a candidate. Somebody had venous thromboembolism in the past and is above age of 60 years, or had a previous CVA and is having weakness and still having a weakness in the lower limb, definitely will be a candidate in case the person is 60 years and above. So many ways one can decide. Finally, it has to be a clinical call. Guidelines are just guidelines. But
Right.
let us say there is a 25 years young man who has just mild degree of fever, little bit of dyspnea, saturation is all right, and you want that, probably he will not be a candidate for rivaroxaban therapy.
Right.
On the other hand, let us say we have a 66-year person, he had a previous angioplasty. Now we know that these people are at a high risk of arterial thrombosis and venous thrombosis also. And he is only on aspirin and statin, and his saturation is borderline, maybe 90, 92%. I would err on the side of giving rivaroxaban to this.
So they are also using 10 mg or 2.5 mg?
No, the 10 mg for a simple reason, because 2.5 milligram twice a day is vascular dose. Right. And here we want to prevent venous thromboembolism, which can lead to pulmonary embolism. And remember, we already said that venous thromboembolism can occur in 70% of individuals, and pulmonary embolism as a cause of mortality has been described in as much as 1/3 of these individuals. So the question actually is preventing DVT, and rivaroxaban 2.5 BD would not do that job.
Right. Thank you so much, sir. Still the questions are coming in.
Please go ahead. Please go ahead.
I have 2 more questions. So one question is there that what should be the cutoff value of D-dimers in mild to moderate cases of COVID-19? That is one. Another is what should be the level of D-dimer to start off with? So I think these are 2 questions which are relatively same.
So first thing, Single reading of D-dimer is not good enough.
Okay.
So typically when the patient has become symptomatic, patient is symptomatic, or patient has got a COVID test positive, get a D-dimer right at that time. And in case it is less than 1000 nanogram per ml, repeat it after a week. If it still is below 1000 nanogram per ml, I will not give any anticoagulation. But if it exceeds 1000 nanogram, I will look at the other factors. If the age allows me, thrombophilia, cancer, previous CVA, diabetes. Remember, I would give 1 mark to diabetes, although the impact score does not have. If there is diabetes itself is a procoagulant situation. If person has diabetes and the D-dimer is more than 1000, I will give rivaroxaban. That is how I will think of. But having said that, my point is don't rely on one value of D-dimer. In case you are doing D-dimer, you would have to do you at least twice, a week apart. And in case there's a rising trend, definitely. And in case the one reading was below 1000, the other is above 1000, then look at other factors before starting it.
There was one more question. I was just going through the questions. One question was, if the D-dimer remains consistently, it is going up despite heparin or despite an enoxaparin being given. So what should be our strategy there?
So obviously, these are the individuals for which we would have to find an answer. Should we be using therapeutic dose of anticoagulation? Or we should be increasing the dose of steroids? Or we should be adding other anti-inflammatory drugs like colchicine? We still don't have answer to this kind of problem. We know that they are at a high risk, their mortality is high, but we don't have data whether therapeutic dose would have benefit these individuals, number one. Number two, whether increasing steroids would help these people. Number three, we don't know whether adding colchicine will help, although we have French data from a study called Col Corona, which says that colchicine does cut down the hospitalization and risk of morbidity in such individuals.
Okay, right, sir. So thank you, sir. We still have one more question. So I will
Please go ahead. We still have time.
Yeah. So, sir, there is one question: is obesity a risk factor for such patients that have been detected COVID positive? Is obesity a risk factor, or is
I would say morbid obesity is definitely a risk factor.
Okay.
That is, if the BMI is more than 35, I definitely will feel it's a risk factor.
It is a risk factor. Okay. And is there any role of statins in COVID? Have you found patients on statins?
So you might have seen a paper which just was published actually a few months back in circulation, and I think it is circulation. I'm not very clear. So what they did was they had the Chinese looked at propensity matching of 110,000 patients, those who were on statin and those who were not on statin.
Yes, sir.
An interesting thing is that those who were on statin had we're talking of 1 lakh, some 15,000 odd people, propensity matching. Again, it is not a randomized study. People who, and these are individuals which also includes hospitalized patient and OPD patient also. An interesting thing is that largely these are hospitalized patients for mild infection, other things. The mortality was 5.2% in case the people were on statin, whatever be the dose, whichever be the statin.
Okay.
And it was 9.7% those who are not on statin. 9.7 versus 5.2. That is 40% reduction in mortality. Having said that, remember, it is the observational data.
Yes.
And it is propensity matching is one way you can reduce the confounders. But it does not say that you will be able to reduce all the confounders. But what do? I give statins to everybody. I believe that data has some meaning because the statins have pleiotropic anti-inflammatory benefit. There is no doubt about it. You know, I would also tell you one other reason why I give it. Remember the Jupiter trial? In Jupiter trial, venous thromboembolism was reduced by 44% by giving by rosuvastatin 20 mg. 44% reduction in venous thromboembolism. I strongly believe that statins do decrease arteriovenous thromboembolism.
Right, sir. Sir, even I think in Jupiter trial, you had elevated levels of HSCRP also. Yes. I think that was one of the important criteria.
One of the reasons.
Yeah. So I think we have summarized a lot of questions. A question has come: level of platelet counts to monitor before starting DOACs. So, should we monitor platelets before we start a DOAC therapy?
So up to 1 lakh, there is no problem. Between 50,000 and 1 lakh, be little careful and monitor platelets adequately. And below 50,000, I probably will be reticent of starting these agents. And I would probably not start it. But having said that, there is no doubt that we need thrombocytopenia essentially means that there is a DIC, and if associated with low fibrinogen level, I would not give anticoagulation because chances of hemorrhage would increase.
Okay. So I think, sir, thank you. I would just like to thank you for answering so many questions. I hope and we wish that all of you back in Delhi stay safe. Sir, we thank you so much for the presentation and a wonderful talk. And so we thank our audience, thank all the participants for listening to us. Thank you so much, sir. Thank you.
Thank you, Curis Mankind, for giving me this opportunity on this Sunday evening to talk. This is one subject we should be talking much more often.
Sure.
Than anything else. And I think we need to have more discussions, more kind of a roundtable meetings where people give their own opinion. The things which we have discussed so far is what is available in literature and what do the guidelines say so far. You have already seen that different bodies have different opinion. European data is different from Chinese data, and European data different from American data. These are all problems which will be there for a disease which is just a year old, and we don't have randomized data. But nevertheless, one thing is certain: whatever is the state of evidence, anticoagulation do play a role. Prophylaxis or therapeutic is a different story, but in a good number of people it plays a role. Should we start early? Should we give to everybody? That question is being answered by Prevent HD study, and I would say at this moment, in case patient does not have a high bleeding risk, a 6 weeks prophylactic therapy of DOACs in people who are symptomatic and more than mild COVID infection is a reasonable strategy. No harm. No harm in using this strategy till we refine and fine tune the indications better. Thank you very much, Curis, and we should have more of these things.
Sure,
for the first time, actually, in last 14 months, since I have been part of webinar and I get involved in 3 to 4 webinars a week, somebody thought of having a very topical webinar. And I need to actually congratulate Mankind for thinking of that. Nobody had thought of involving us in a structured manner in such a program. Thank you again.
Thank you so much, sir. Thank you. And we look forward to meeting with you, interacting with you. And we hope that, sir, you stay safe and you keep on helping us in a pandemic like this. Thank you so much, sir. Thank you.
Thank you, Ritesh. And thank you, Curis. Thank you, all the viewers, all the audience. Thank you very much.
Thank you. Very good.